Good morning, all my friends in India, and good evening to all those who are in the United States. It's a wonderful occasion that we are in we have completed 90 episodes, and this is the 91st of the series of continuing medical education programs being conducted by Andhra Medical College on educating about this COVID-19. And this has been possible, as you all know, with the help of many. And I want all the postgraduates and the faculty to understand that this wealth of knowledge has come from experts from various fields. And like every time I reiterate that this particular program has been taken on their shoulders by Dr. Sridhar Chilamuri and Dr. Ram Kairam. Both of them have been the pillars. And I want all of you to realize one thing. Like we see many heroes, the COVID warriors, so on and so forth. But I always feel that Sridhar Chilamuri is a real COVID hero because he has been not only treating the patients as a physician, but he has been an extraordinary leader in his big facility that he is running in New York, as well as he has been a great researcher. And by contributing enormously to this knowledge, on this platform, he has made all of us aware of what needs to be done. And he has come in the times of crisis and explained all of us as to what needs to be done. And through his publications, you all can make out as to how important these contributions have been. And at the same time, if you realize that the opinions or the expertise of people like Sridhar and Ajay Noka, who spoke last week, we all read in the textbooks. So whatever that comes in the textbooks are basically the ideas and the experiences of people like Dr. Sridhar Chilamuri. So I'm so glad that I have him in many of these sessions. And at the same time, Dr. Prasad CVR, he has been, we three used to hang around in Visakhapatnam when we were undergraduates. And he was he's a great friend and a bosom friend of mine who lives in Australia now and an extraordinary cardiologist. And I'm very glad that he's also here to moderate this particular session. He's an extraordinary cardiologist, the best outgoing student of Andhra Medical College. Later, he was the topper in his MD also at PGI Chandigarh. He did his DM in PGI as well. And he worked in Hyderabad in various hospitals for some time and later moved to the Australia, where he got a very good name. So he has kindly accepted to be the moderator for this session. This session is very important because Prasad Chalasani, he is coming for the third time on this forum, but every time he comes with an update. And this time I requested him to speak on the long COVID, the cardiac manifestations of long COVID, which people are experiencing these days quite often. And having Prasad Chalasani on the forum, who helps Andhra Medical College from time to time, not only by donating, but also by contributing his expertise, being the visiting professor to the Department of Cardiology of Andhra Medical College. And Dr. Prasad, CVR also is a visiting professor. So now we have both the speaker as well as the moderator, the visiting professors to Andhra Medical College for the Department of Cardiology. That's a rare coincidence, but I'm very glad that both of them are there. As you all know, that Prasad Chalasani has been the best outgoing student from Andhra Medical College. Anyway, Dr. CVR Prasad will be introducing. For this session, we are missing Dr. Ram Kairam, who has been always in this. He is actually shouldering the responsibility of having the right speakers at the right time. And he's so balanced. Sometimes he makes very caustic remarks, but at other times he makes wonderful remarks in the form of beautiful advices. So we are missing him this week because he's on a trip. So I'm sure that for the next week, next session, Dr. Ram Kairam also will be joining. So I'm planning to have this particular program, this series, up to 100 before I call it a day. We have After this, we'll have 9 more to go. And the 100th one, I'm trying to have it as a hybrid, we'll have a big screen and all the students and the postgraduates to watch directly from the experts. I'm planning to have a panel discussion on all the problems that we are facing day in and day out and what we have seen. It's a sort of a recap of almost the 100 that we will have by that time. So other contributors it's not only Dr. Sridhar Chilumuri and Kairam themselves directly involving, but also they have made their staff who are experts in the respective groups to talk to us, so that we all got so much of knowledge on this particular topic. Like Dr. Kalpalata Guntupalli has been very kind to introduce so many very good speakers, like Dr. Kulkarni. Similarly, Dr. Sridhar Chilumuri has introduced many people like Dr. Muhammad Adrish and many others from his own department, so that we all had very good knowledge. And people like Dr. Prem Kumar from here in India, from our own place, also has enormously contributed to our knowledge. So with these few words, I will not take much more time, and I request Dr. CVR Prasad to introduce Dr. Chalasani, though he does not require any introduction, as a formality, and at the same time for the people who have just joined, who have not joined earlier, it will be useful for them. Over to Dr. CVR Prasad, and we will take up the expert comments from Dr. Sridhar Chilumuri towards the end of the session. And meanwhile, he will be seeing the chat box, also following the chat box. So over to you, Prasad CVR.
Thank you, Sudhakar. At the outset, thank you for this opportunity. It looks like the only qualification which I have to get into this meeting is being your friend. Thank you for that. I have the honor, pleasure, and privilege of introducing Prasad Chalasani, whom I had the opportunity to meet in 1988 in Chandigarh. After his basic medical training in Andhra Medical College, he had his internal medicine and cardiology training in Emory, which is one of the distinguished medical schools in the US, and did an interventional fellowship there. He is a board-certified cardiologist for interventional cardiologists, as well as for nuclear, CTCA, as well as other aspects of cardiology, and that's probably one of the important aspects of his multi-faceted capabilities. He held various positions in various hospitals. Currently, he is the chief of cardiology at the Lawnwood Regional Medical Center and Heart Institute in Florida, and he has also been an attending cardiologist to many of these institutions around that place. He is a proctor for most of the interventional procedures, which includes the TAVR, MitraClip, and percutaneous closure of the ASD and other things, for Edward Life Sciences, as well as for Medtronic, one of the companies which manufacture these stents. He also has the distinguished privilege of publishing extensively, and I don't think we'll have enough time to go through all of that, but just to suffice to say that he has got enough research experience and is part of many of the trials, national and international. I'm very honored and privileged to introduce to you Prasad Chalasani. He is a fellow of the American College of Cardiology, the fellow of the Society of Cardiac Angiography and Intervention, and fellow of Society of Cardiac CT. I'm sure there are many more things to add, but I thought we should not take more time and stand in between you and his lecture, which we are all looking forward to eagerly. Thank you. Over to Prasad Chalasani.
Thank you, CVR. And I really like to thank Dr. Sudhakar for giving me an opportunity to speak and share some of my experience, and more so going through the literature about this long COVID. Of course, I really want to congratulate Dr. Ramohan Garu and Sridhar Chilumuri for tireless efforts to put these programs together. Today, my topic is cardiac manifestations of long COVID-19. It's very appropriate because it's been about a year and a half since we started seeing COVID. We talked extensively on multiple platforms about the cardiac manifestations during the COVID. But exactly what we're seeing is now the epidemic of COVID, post-COVID manifestations. So I'll try to find some literature and I will give my personal experience as well. So Always I start my talks with my guru, Dr. Hurst, who really nurtured me to be a scientist, an educator, and a compassionate physician. He was truly a giant in cardiology, and as a human being, especially the moral values, he amazed me when I was working with him for 7 years at Emory. So the COVID-19 and the heart, we talked about the acute manifestations. I'll have one slide just to rebrush ourselves, and then we'll talk about the COVID-19 long haulers as well as the long COVID or post-COVID syndrome. So we'll try to see what these definitions mean, what exactly we understand. The acute cardiovascular manifestations, as I presented in the past, they present with STEMI and sometimes as a pseudo-STEMI. The patients have ST elevations, and when we do the heart catheterizations, they have no lesions. And every patient in ICU pretty much have increased troponins. Even on the floors, we have a high troponin leaks. And patients who have a myocarditis and a pericarditis, congestive heart failure, cardiomyopathy, arrhythmias, atrial fibrillation, and quite a bit of ventricular arrhythmias in the early cohort of patients where we were giving chloroquine. Acute thrombotic events are actually a lot more than I predicted initially: cerebrovascular, peripheral arterial, and venous thrombosis. In fact, most of my COVID research is in this arena of thrombosis, both peripheral and coronarious. So I brought this slide just to say how the science has changed a year ago. A year ago in September, I gave a lecture on COVID-19 and acute. At that point, there was almost 33 to 35% of the patients in ICUs have atrial fibrillation with COVID-19. And the paper concluded, it was of course an observational study, atrial fibrillation was very common in COVID-19 and represented a high risk of death in patients with COVID-19. A year later, this is just a very a fresh article out of JACC EP. What we're trying to learn is COVID-19 represent a spectrum of viral infections. There may not be specific, there are some specifics, but some of the cardiovascular manifestations represents a global pathophysiology rather than pertaining to COVID-19. Atrial fibrillation flutter is no more common than in any patients with any flu, pneumonia, viral illnesses, and with all the comorbidities. But it does represent a higher mortality, almost 75%. All it tells us is these are the patients who are hypertensive, on the ventilators, hypoxic, on vasopressors. They all have a high AFib, and those are the high patients who are high mortality. So it's kind of a common sense. The paradigm changes, revolves around to the same where we started a year ago. So I'm going to start the long COVID with two of my cases. And I just want to represent what this long COVID represents. A 40-year-old Indian pharmacist, very active man, is very thin, plays tennis, you name it. He received his J&J vaccine. 4 months later, he developed COVID-19 Delta variant infection. He was hospitalized for 7 days, and he received oxygen along with remdesivir and steroids. And he presents 6 weeks later to my office because it's not getting better. He walks 10 yards and he gets desaturates, and he has a persistent chest pain, and he has a lot of palpitations and dizziness. His resting heart rate is about 90 to 100, and he walks from the front of my lobby to my exam room. His heart rate was 140 to 150. So we did an EKG, it was a sinus tachycardia. Echocardiography revealed normal left ventricular function. The right side chambers are normal, structurally normal heart. And we did a CAT scan of the chest, which revealed bilateral extensive infiltrates, as one would suspect. And still patient requires oxygen from time to time. So this is particular patient given pharmacist. We wanted to explore the possibility of myocarditis, so we did the cardiac MR, which of course showed patchy gadolinium enhancement. So that's our first case. The second case is a 45-year-old nurse in our hospital. She's vaccinated with Pfizer, had a COVID-19 infection 4 months after vaccine. It's mild to moderate disease. She was not admitted to the hospital, was treated as an outpatient. 6 weeks later, gets admitted to the hospital with atrial fibrillation with the RVR and leg swelling. During the hospitalization, we found the patient has DVT in the right leg and was started on anticoagulants with novel oral anticoagulants, and the CAT scan was negative for pulmonary embolism. 2 weeks later, she comes again with the recurrent chest pain, persistent palpitations, fatigue, and syncope. We watched her in the hospital for 48 hours. There were no arrhythmias, very labile hypertension, and heart rate. Cardiac workup, troponins were negative, negative EKG for acute changes, negative echocardiography. That means normal LV function, normal right stent chambers, no wall motion abnormalities. Patient was started on beta blockers. Last week I saw her in the office, still not feeling good. She's on disability for last 3 months at this point. She's one of the first patients with the Delta variants in our hospital. So what exactly this long COVID mean? I'm going to go back to those cases, how they fit into our long COVID. So this is a definition I found probably more accepted. The long COVID is includes ongoing symptomatic COVID-19 from weeks 4 to 12, and post-COVID is a syndrome after 12 weeks, after 3 months. As I said, there's no agreed general definition. So the first cohort of patients, ongoing symptoms are COVID long haulers, and the post-COVID-19, both of them are under the umbrella of long COVID, COVID-19. This long COVID has really created enormous burden on the healthcare systems because a lot of the healthcare professionals are off. It produced a lot of economic damage and productivity losses. And I think it's going to be the next 3 to 5 years a modern medical challenge of first order for the society and for the medical professionals. So long COVID-19, I did an extensive search this week to find out some of the bona fide articles on this topic. There are multiple observational studies. I think I have about 4 good studies that I picked up, which has a good peer-reviewed articles. So much of talk, but very little confirmatory data. COVID-19 stories, everyday news, as you can see. As I was today reading, and I found out the article from Canada about long COVID. So we learn every day, and I think it's going to become more and more solidify as months and years come by. And I'll share some of my personal experience, and also I'd like to give my projections on this COVID-19 and cardiac manifestations. So what are the common symptoms on long COVID in cardiovascular arena? Chest pain is a very common, it's mostly persistent, and it's nothing like the angina that we always get in the history. And those patients have palpitations, they become tachycardic, they get shortness of breath, fatigue, extremely common symptoms, decrease in exercise tolerance. And as we go on to a little bit more serious, less incidence is acute myocardial infarctions and strokes, arrhythmias, atrial fibrillation, myocarditis, cardiomyopathy, congestive heart failure, and quite a few patients have psychological symptoms and depression and worsening chronic conditions. And I have a very good study in the slide that shows how this COVID-19 has worsened chronic cardiac conditions, both heart failure, coronary ischemic heart disease, and arrhythmias. So the number one syndrome that we always come across post-COVID cardiovascular manifestation is PART syndrome. The reason I spend a little time on this is about 15 years ago, I never seen a patient with PART syndrome. And if somebody comes with this, I thought the patient was a little crazy. I'll be honest with you. But in the last 6 months, I've seen more PART syndromes than entire my cardiology career, probably 100 times more. Every day I see 2 or 3 of these patients. This is a syndrome basically has tachycardia, heart rate goes up 30 beats when standing. They all come with the tachycardia, lightheadedness, palpitations, weakness, and blurred vision. They all have autonomic dysfunction. The hypothesis, though never proven, is they have antibodies against alpha receptors and antibodies against muscarinic receptors. So there is a reason why we think it is a totally disbalance of autonomic nervous system contributing to the syndrome. And it is commonly seen in post-viral syndrome, not only COVID-19, chronic fatigue syndrome. 90% of them improve over the time. 25% of them are unable to work at this point. The treatment includes increasing water and salt intake, wearing the stockings. I use beta blockers routinely because most of these patients also have hypertension. So it's a very challenging problem. We use a quarter of metoprolol to half to one, slowly building up. And I use fluorocortisone, Florinef, very routinely. Very rarely I use midodrine, proamotine, which is a sympathomimetic drug. But this is what they've been advocated. And of course, a lot of SSRIs has been used in this syndrome because they have a concomitant psychological issues, depression in these patients. So the incidence of long COVID-19, again, this is a moving target. I can tell you in this particular study, 1/3 of the adults with mild COVID not requiring hospitalizations have not returned to their normal health 2 to 3 weeks after positive testing. The patient population includes young, healthy adults, and the 13% are still symptomatic after 1 month, 5% at 2 months, and 2% at 3 months. But the latest data that came of the Canadian Health today, they published over 10% at 12 months. And that's a very underestimation. I have some studies that shows almost half of the patient after 3 months are never back to normal. So this is a real patient concern. This is not something you can see a bad chest x-ray or a bad echocardiogram and say this patient is not doing well. How well-being of a patient is equally important in the practice of medicine. So I think science is one side, and the art of taking care of the patient is on the other side of the paradigm. And this is where we really have to start taking care of these patients where they don't have absolutely no objective evidence of something wrong with them, but they have a lot of symptoms. And they're true because they're disabling them, they cannot function, they can't go back to the work, and this is a social and economic burden for the country and for the physicians. So I'm going to start, as everybody would project, from China. The Wuhan was one of the first studies published in Lancet. It's a 12-month outcomes from the largest longitudinal cohort. It was just published not too long ago. Adult survivors of COVID-19. These are the hospitalized patients. And they include adults, average median age is 59. At 1 year, most of these patients, half of the patients have mobility problems, pain and discomfort, anxiety, depression. They are compared with the matched community adults without COVID-19. Fatigue and muscle weakness was most frequent symptom at both 6 months and 12 months, while almost half of the patients reported having at least one symptom of either sleep difficulties, palpitations, chest pain at 12 months. So the point here to take is even in China, where the reporting is a little bit challenging and underreported, quite a few patients are forthcoming saying that they did have a persistent symptoms even at 12 months. So this is from United Kingdom. This is a very good study. It's a prospectively followed patients on a self-reporting. They used 327 patients, prospective multi-centered cohort, at least 3 months post-discharge. They were given certain questionnaire for the self-reporting. One of them is mainly the symptoms. The other one is about their disability index, quality of life. All those three really affected after 3 months. The fatigue was 83%, persisted after 3 months, shortness of breath 54% of the patients. At 10% of the patients in their reported quality of life was significantly reduced. And in fact, in that study, 25% of the patients did not report back to their work. And a quarter of the patients were a disability. That's what I meant. So most of the patients were females under the age of 50, and the people who had acute disease in hospital has the worst long-term outcomes. This is a Veteran Affairs study from the United States. The VA is probably the largest single database hospital system in the United States. That has close to 3.7 million population patient database. And so this particular study is what they looked at. Most of these patients are all Caucasians, white, and male. So they're very, very few. So there is going to be a lot of bias in this study because of the patient population. But what they looked at is what are the effects of the COVID patients and non-COVID patients in terms of the cardiovascular morbidity and mortality at up to 12 months. So they found non-hospitalized COVID patients had 39% increased risk of heart failure and 2.2-fold increase of pulmonary embolism. This is, think about it, 151,000 patients versus 3.6 controls. So this is a very large study. The p-values are enormous. And the works out about 5.8 cases of heart failure and 2.8 cases of pulmonary embolism for every 1,000 COVID patients who were never hospitalized. These are non-hospitalized, mild to moderate. If you come to the hospitalized patients, these are even much higher, 5.8% increase in cardiac arrest, 14-fold increase in myocarditis, and COVID patients needed intensive care unit at even a greater risk. So all it points out to is the severity of COVID proportionately increased the cardiovascular morbidity and mortality. Not necessarily direct effect by COVID itself, but it has worsened the existent cardiovascular issues. I think that's the most important message here. And this is in a table form, again, looking at the cardiac arrest, stroke, heart failure, pulmonary embolism, myocarditis. If you look at the percentage of these patients increased is enormous, how much. So let's talk a little bit about the COVID, long COVID-19. And everybody talks about myocarditis. That's a term that very popular courtesy to the media, both in the vaccine and the long COVID, how reality it is and how much it has a long term. So this is a study that really talks about from Frankfurt. They took 100 patients, irrespective of, they're all volunteers. They participated as part of the study 10 weeks after they were positive. Some of them are hospitalized, some of them are not hospitalized, but they did a cardiac MR. It was in Frankfurt. And 3 out of 4 of them have abnormalities on their cardiac MRs with enhancement of gadolinium, patchy uptake. So they concluded there is a very high incidence of myocardial enhancement in CMR with a possibility of myocardial inflammation. This is a proposed hypothesis. It's in JAMA in September last year. Hypoxemia, hypercoagulability, ARDS causes inflammation and cardiac remodeling. The final net product is a diastolic dysfunction of the left ventricle. They all develop heart failure with preserved ejection fraction, pulmonary hypertension, right ventricular dilatation. So this is, the last 2 are directly secondary to the pulmonary pathology. These are the patients who have advanced pulmonary involvement with pulmonary fibrosis, that develop pulmonary hypertension and secondary RV dilatation. And of course, as we suspect, initially they thought it may be directly from COVID infiltrating the myocardium, but most of the data suggests it's more of a cytokine-induced or toxic and other reasons rather than COVID-19 virus direct damage, though we have a lot of autopsy specimens showing COVID-19 in the endocardium and myocardium of the hearts. So I'd like to talk about what exactly, how we define a myocarditis. It's very important when we're doing a research study. Anytime when we do, we have to define. This is a consensus agreed upon by the European Society of Cardiology, American College of Cardiology, and the International Congress. These are the definitions of myocarditis. You have a suspected case. If anybody comes in with a shortness of breath, chest pain, or palpitations, if they have one of the following, if they have any EKGs, abnormalities, either STT changes, or if they have a paroxysmal atrial fibrillation or PVCs or any ventricular arrhythmias, or if they have a conduction system diseases, and if these patients have a focal or diffuse LV depression of unknown time, if there's a first echocardiogram and if they found some abnormalities on the echo, they need to have one of the two, either EKG or echo findings along with symptoms. Then we suspect those patients. And then we move on to probable case. All these patients, if they have increased cardiac enzymes, like a troponin I, or one of the increase or a new onset of reasonable wall motion abnormality on the echocardiography, or if they have an abnormality on cardiac MR. I don't think anybody has done a gallium-67 scanning in the United States, but CMR is routinely done in most of the institutions here. So if they have one of those abnormalities along with the symptoms, along with either EKG changes, then they constitute a probable case. What is a confirmed case of myocarditis? This is so important from public reporting perspective. They all have to have symptoms. They have to have either EKG changes, or they need to have all of the following abnormalities: elevated cardiac enzymes, abnormalities on the echo, and abnormalities on the cardiac MR. So when they have all those three, along with symptoms, along with the EKG changes, that constitutes confirmed cases. So this is a study out of Ohio State University athletes. These are the student athletes. They looked at involvement of the pericardium and the myocardium. And you could see in this slide, this is a pericardial enhancement. And here, and the next slide, you can see a myocardial patchy uptake of the gadolinium. So when you look at this cohort of patients, about 33% of the patients have myocardium and pericardial involvement. So in conclusion, 1 in 3 patients of healthy college athletes recovering from COVID-19 showed resolving pericardial inflammation. They have subtle changes in the myocardial structure and function, showed specific imaging features to suggest ongoing myocarditis. Further studies are needed. The conclusions were, this is basically American College of Cardiology and North American Professional Sports Leagues put together how to deal with this problem of athletes clearing for their sports, both at the college level, at the professional level. So I looked at these patients, they followed for another 6 months and see what is the incidence of any of those patients who are positive, either because of their abnormal echocardiograms or positive troponins or positive CMR findings. And none of them had any cardiac adverse cardiac events. So all of them were returned to play, except 2 players in the national sports. So what we started doing, the guidelines suggest anytime I screen these athletes for the New York Mets, which I do, they all have to have a troponin, an EKG, and echocardiogram. If they're all normal, I clear them. But if any of them have abnormalities, then I have to get a cardiac MR. If the cardiac MR is normal, I clear them to go back to the professional game. But if cardiac MR shows patchy uptake, I keep them for 3 months on the bench and we repeat the cardiac MR and the echocardiography. This is pretty much the national guidelines for the professional sports and the college sports. And these are the guidelines released, I would say, within the last few weeks by the ACC and the Exercise Physiology Committee. Exercise and post-COVID-19. Current recommendations for resuming exercise after documented COVID-19 infection in highly active people. These are not the people elderly. We're talking about 20, 30, 40-year-olds who are very active, do marathons. They're very eager to get back to work. So they're asymptomatic. We recommend them not to do exhaustive exercises for 2 weeks, close monitoring for symptoms, slow resumption of exercise. If they have a mild post-COVID symptoms, non-hospitalized patients, rest for 2 weeks. We need to evaluate with an EKG and an echocardiogram before we return to the exercise. Those are patients who are hospitalized for severe COVID-19. We have to evaluate during the hospitalizations and 2 weeks after discharge. We do them EKG and an echocardiography and close monitoring and slow resumption of activity with close cardiac follow-up. These are the guidelines just posted recently. So this came up this week, New England Journal, because there is a lot of uproar about the booster shots of the COVID-19 Pfizer vaccine about myocarditis. And this is the two largest studies published in this week of New England Journal. I picked up one, pretty much says the same thing. Among the patients, large Israeli healthcare system, all the patients who got mRNA vaccine, at least one shot, estimated myocarditis. This is a confirmed myocarditis, 2.13 cases per 100,000 persons. The highest incidence was between the age of 16 and 29. Most cases of myocarditis were very mild and moderate in severity. In their cohort of patients had 1 mortality and 4 cases of fulminant myocarditis. So the highest incidence of myocarditis is among the young male patients, age of 16 to 29. So it's very important. So I'm going to move a little bit more broader rather than cardiovascular. What is the long-term COVID effects on the healthcare itself? I think in the United States, typically telemedicine has taken off because a lot of us do telemedicine. It is helping a lot of minor things we could do through telemedicine. It helps the patients to manage their time. And of course, we're doing a lot of remote monitoring, EKGs, blood pressures, et cetera, et cetera. So this has taken off, and I think it's going to be there in future. I think the entire healthcare system have realized the importance of this. Education, the positive effect of the COVID on the education is you've been seeing some of the best speakers you otherwise couldn't have heard are on the Zoom, like Dr. Sridhar Chilumuri, et cetera. And now they're giving their expertise, and all the students, fellows around the globe can really benefit from some of these best speakers. And that's a positive front on the COVID, what has done to the healthcare system. And of course, lack of personal interaction between the patients and seeing the healthcare providers in the lounges and unable to share the patient information person to person, it affecting the mental health. There is quite a bit of a physician burnout. And I think our goal at one point is to get back to the days of hugging patients and shaking hands with colleagues. I think that's where real pleasure of being a doctor is. So what are the predictors of long COVID-19? Women, young group, 20 to 40, there's a 4 to 5-fold increase. And obese patients, and of course, severity of COVID-19 illness in some studies have shown. But the conventional risk factors like the diabetes, heart disease, et cetera, has not really correlated with the long COVID syndrome. I want to thank my family and thank one and everyone for your attention. So I think I'd like to have more dialogue rather than me giving a lecture. I thought that's a lot more fruitful, and I could share my experience, and I'm sure other Sridhar and everybody else can also share their experience and ask questions. So the podium is open for questions. Back to you, CVR.
Thank you, Prasad. I think it was a wonderful disposition of the cardiac manifestation of COVID. I must say that, living in Brisbane in Australia, I have never seen a COVID patient so far. There's only one hospital here which takes COVID. The total number of COVID patients in Queensland is 400. And they're all mild. Everybody gets admitted. So it is a big learning exercise for me, and thank you very much for that. Now, to set the ball rolling, a couple of questions from my side. I'm sure there is a couple of questions in the chat box, which I'll also open up. Let me go to the chat box first and ask the questions which they have asked. One of the questions is, can COVID myocarditis cause papillary muscle rupture and cardiogenic shock from acute MR? This is from one of the chat box questions.
So in our experience, we had one patient of fulminant myocarditis, with not necessarily papillary muscle rupture, but cardiogenic shock and flash pulmonary edema. And that patient was put on ECMO and did very well. Believe me or not, that patient with aggressive steroid treatments and whatnot, 30 days, I remember, on ECMO, and were able to come off the ECMO, did quite well.
Thank you. The second question on the chat box was, how common are these long COVID cardiac problems in Indian population? I presume they are already there, but we are not probably recognizing them enough. What do you think?
I can comment on it. I think some of the Indian colleagues should speak about how much. I can tell you in my practice now, every single day, I would say 4 or 5 new patients come with the COVID, post-COVID cardiac symptoms, especially young patients. And they're very challenging because it's not like somebody with classic exertional angina. I tell them, okay, I'll catch you tomorrow. These patients take 15, 20 minutes. And at the end of the conversation, they're not very happy because they don't feel better. They come back a week later, 2 weeks later, this medicine didn't work. And I tell them every test is good, but still it's a challenging. I think we're learning how to deal with this cohort of patients.
No, thank you. I think I definitely think there would be significant symptoms in Indian patients as well. We are no different from the others. And I'm sure people will look into this prospectively with this knowledge which you have provided. One question from my side, Prasad. Did you think that the incidence of long COVID symptoms were lesser in people who have been extensively treated with steroids and the incidence of myocarditis was lower?
Not necessarily, because those are the sicker populations. So their fatigue and short of breath is a lot more pronounced and palpitation. That's a lot more to do with being intolerant to exercise, being in the ICU for some time, or otherwise steroid myopathy, for all those reasons. But a year out, there are a couple of RP friends who had 6 months really downtime, and they're now the president-elect of RP. She went through hell. She was on Cleveland Clinic on lung transplant, but she has so much of energy, unbelievable. So there's some great stories how some people got back, and some people with very mild symptoms are really disabled from this disease.
Okay, wonderful. The other question I was wanting to ask you was that you've said a couple of these people who were having mild COVID on follow-up with the CMR had a gadolinium enhancement, patchy gadolinium enhancement. Do you do any treatment for them or just to observe and watch?
Watch. If they have a normal LV function, they don't have any symptoms, we just watch. And some of the athletes, etc., we do a follow-up CMR, but otherwise we don't. We just follow with echocardiography.
Wonderful. One of the questions from the chat box is, can monitoring of cardiac enzymes a useful alternative, and how long should we monitor for looking at long COVID infections?
Oh, I'm a big believer of not doing it, honestly. It really creates more a mess than anything, because I tell you, every single day I see 20 to 25 new consults for positive troponins in our COVID group, because all it tells us is the severity of the illness, systemic process rather than a direct myocardial. But on the contrary, if a patient comes back 6 to 8 weeks or 12 weeks later with a chest pain and has a borderline troponin and some EKG changes, that particular cohort of patients we need to follow through. But not every hospital. In acute, I do not believe they have a bad prognostic indicator, but that's expected. That's exactly like AFib, exactly like BNP, that all represent the severity of systemic illness rather than primary cardiac etiology.
No, thank you. That's what my understanding was, that they're good for diagnosis, not good for following up or prognosis-wise. Another question, last question from my side is that we've all known that the myocarditis incidence was higher with the Pfizer and the Moderna vaccines. Has anybody looked into AstraZeneca, which is the common vaccine which is used in other parts of the world? Is the incidence of myocarditis the same, or is it much lower than the Pfizer vaccine?
I'll let Sridhar answer that question.
Yeah, I open this for discussion, and Sridhar can pitch in and then give his thoughts. We would definitely like to listen from him about his expertise.
In terms of vaccine-mediated myocarditis, it's mostly in young people. So you don't see older adults getting myocarditis from vaccine, although there are some case reports of it. I think the current experience is Moderna may have the most, and probably because you give a much higher dose of mRNA than Pfizer would. So Moderna has the most number of reports with myocarditis, but almost always they are in young children, mostly male, and secondly, after the second dose of the vaccine. So, but we are now recognizing a lot of people in the United States who suddenly come up with severe cardiomyopathy of unclear etiology. And you go back and review the history, either they had COVID a few last year or a few months ago, or had a vaccine in the last 6 to 8 months and may not have any symptoms at that time. But 6 months later, they seem to have heart failure with cardiomyopathy. You could argue any viral myocarditis would have done that, but it is something that we're observing overall. You have to see if the rate of heart failure in the United States is going up and how much of it is because of viral or vaccine-induced myocarditis leading to cardiomyopathy. So both Pfizer and Johnson & Johnson and AstraZeneca all had case reports of myocarditis. So none of them were, were sufficiently of concern. I think Moderna is the one for younger people. I think the Scandinavian countries decided that they will only give 1 dose of vaccine from now on for children because they think the risk of myocarditis is higher than risk of dying from COVID. So they're going for 1 dose. In the United States, they're going to give half dose of the vaccine because they are concerned about myocarditis in the younger population.
Yeah. Thank you, Sridhar. Thank you.
I have a question. I have a question, Raghu, if you permit me. Prasad was referring to that NEJM article of the incidence of 2.1 per 100,000 post-vaccination myocarditis. I just wonder as to what the base rate is. In that age group, do we ever see the myocarditis? Or number 2, how do we relate that to the post-vaccination? If there is none in that particular age group earlier, perhaps this could be because of the vaccination. How to relate the vaccination with the myocarditis, number 1, and what is the base rate? Would people in that age group ever suffer from myocarditis otherwise?
To answer that question, Sudhakar, in that particular study, the control is basically 0%. It's they used the cohort of patients historically. But the important thing is these are the new myocarditis along with the echo findings. They followed the criteria strictly in this study. And again, I think if you look at 2.3% for 100,000, if you extrapolate to millions, that we're given instance. But the key here is they're all mild to moderate. They are just have an inflammation. They have no consequences. That's still. And the third question we don't know is this is a first dose followers. After the third dose, we all know the second dose increased the myocarditis even more. And the third dose is likely to increase. That's one of the reasons why FDA was very reluctant to give green signal for a third dose of Pfizer for young people, healthy people, unless they have risk. And that was a very good reasoning. I think they withstood the political game and they stood their science and they said no. And I think that's the right thing. Young patients should not receive the third dose at this point. And that was the rationale. But the 2.3 is an absolute increase compared to the cohort of patients who didn't have for the same age group.
Thank you.
Thank you.
There are a couple of questions in the chat box here. One of them is, what is the drug of choice for tachycardia? How long should it be used for post-COVID long haulers or post-COVID cardiac manifestations?
I always use short-acting metoprolol, and I start with 25 milligrams. And typically, if their blood pressure 90, I start with half, and I tell them to take as needed another 1 or 2 in a day. And most of the time, they get it at night when their brain is not preoccupied. And the second thing I do for 3 months, and then I slowly taper off. That's my standard.
Thank you. Another question from chat box is, can you please comment on low-dose radiotherapy for post-COVID complications?
I have no experience. Maybe Sridhar can enlighten us a little bit.
Right.
Radiotherapy? No, we have no experience with it at all. And I wouldn't recommend it at this time unless we understand what are you trying to treat with radiotherapy. I think The mechanism we feel is antibody mediated at this. So two possible mechanisms we think we are dealing with. One is a model that's similar to measles. If you recall, when people get measles, a small percentage of them go on to develop subacute sclerosing panencephalitis. In that group of people, what happens is they're unable to completely clear the measles virus. And so incomplete measles particles or small amount of viral particles remain, and they develop an ongoing inflammatory disease secondary to it, and they develop SSPE. We think long COVID could be one of that mechanism. That's one possibility. The second is when you get all these antibodies, the nucleocapsid antibodies, if you recall that most of them, the worsening of the disease happens in the second week of the illness, where these antibodies are now have peaked. And it's actually antibody-dependent enhancement of the adverse event that happens. So we think long COVID may be the remaining antibodies that persist in your body continuing to have adverse response against you in terms of it's sort of an autoimmune enhancement by the antibodies that you proposed. So I can't see how radiotherapy can be any value to that. So I wouldn't try that at this point until we understand the mechanism a little bit more.
Thank you, Dr. Shafi. Would probably, yes.
So, Sudhakar and Sridhar, this is Suresh. Sorry, I missed so many of the talks. Okay, since the antibody issue came in, I just want to give a couple of my comments on that. And that it is now we're getting into more and more in-depth research into the autoinflammation. Autoinflammation seems to be the reason for the most of the COVID inflammation, and especially with the nets and everything that we are realizing more and more. So that is the reason. It's probably just antibodies is probably the end result, but the autoinflammation involving the Treg cells and Th17 cells, those combination and those irregularities we are seeing more and more in the long-term COVID. So it is a similar kind of same autoinflammation we see with many other viral illnesses. Because they're sporadic, we would not recognize it until now. And the second comment I would like to make it is, some of these symptoms that we are seeing may not be only cardiac related, because the autoinflammation is there throughout the body. Every organ in the body is affected by the autoinflammation. So many of them we are seeing now, even with the pancreatitis and hepatitis, kidney involvement, most of the multi-glandular involvement. So this, the whole autoinflammation causing all over the body is probably resulting some of the long COVID effects that unexplained. Their dysregulation of the whole immune system. So it is probably just not the antibody. The second thing comment was, as I was talking before multiple times, is it really needed to give a booster dose for anything younger than 65 or those who are not immune deficient patient? It's many of my Indian friends ask me all the time, we get the Covaxin or we have the Covishield. Again, I think I better to get the Pfizer vaccine when they come in here by different reasons. I strongly recommend them not to do that, because most of these patients, those who already got immune system stimulated, there is absolutely no reason, because many of them, they may get infected, but the disease is very, very small incidence. So they don't get into overt disease. So I rather ask them, if they get the disease, take an antibodies or antibody cocktails rather than taking into more of a third dose of vaccination. I think I did talk to a couple of times, Chalsani, Dr. Chalsani. So we have to be very careful when we're talking about proposing the booster dose in the long run.
Thank you, Dr. Suresh. Yes, Prasad.
Prasad.
Go ahead.
I just want to say that I don't agree with him on his conclusions on the booster dose. I think here's what I want to say. There are a whole bunch of people who got infected in 2020. That was a different variant altogether. I think in India, most of them, or a very large portion of Indian population, got infected with the Delta variant. I think if you got infected with the Delta variant, you're very likely to have good immunity against this prevailing variant. We have no evidence that people get reinfected with Delta variant. So if the vast number of people in India got Delta variant infection, I'm okay with them not getting booster doses. But if they got infected last year in 2020, they probably either got an alpha or a beta, but definitely not Delta. Those individuals are likely to get infected again with Delta. So if they have major risk factors and if they've received 2 vaccine doses and 8 months has passed, I would definitely boost them. And we do see a fair number of breakthrough infections now, and most of them occur in people who either got infected with the non-Delta variants or who got the vaccinations earlier than anyone else. Like we got it in January of second dose, we completed in January of 2021. So we are already seeing breakthrough infections in many physicians now in the United States, physicians, nurses, and whatnot. Now, it is true that we get a very mild infection, but do you really want to be infected? That Suresh wants to get infected just because it's mild? I don't think so, because he can't predict what would happen to you afterwards. So therefore, the goal is not to get infected at all. So if you never got Delta infection, and if you have risk factors, if 6 to 8 months have passed since your second dose of vaccine, I think there's enough data to show good data that you should be vaccinated. Now, if you say, oh, don't worry, nothing will happen, well, you will get infected and some will have persistent of symptoms, and that's a problem. Now, the vaccine-mediated antibody and the infection-mediated antibody are quite different. We have not seen vaccine-mediated enhancement of antibodies adverse events, not seen it at all. That's the beauty of these vaccines so far. That's why they've been so efficacious. Infection-mediated antibodies, on the other hand, can cause antibody-mediated enhancements causing adverse events. One more point, when you boost antibodies again and again with vaccines, it actually improves antibody affinity, meaning it combines and neutralizes viruses even better. There is data that's emerging in that direction. I think Israelis have shown that. I don't agree with, show us data that it's harmful, and then we will say, okay, we'll take it under advice. But I think otherwise I wouldn't make statements. The CDC has advised taking booster doses, and we are taking them, and we're doing quite well with them so far.
Sridhar, for correction, you really need to be very careful when you said the CDC and FDA did not recommend under the age of 65 for all the players.
I didn't say, I said people with risk factors. I didn't use age.
The audience want to make sure they take home message.
And then, by the way, the boosters are only approved for Pfizer. So if you got your Pfizer dose in the United States, that's what we gave. And 8 months have passed. So most of us, actually they use 6 months. 8 months is what we are at. We would recommend it. But
Thank you,
anyway,
Sridhar. I think there are a lot of questions in the chat box. Let me go through
yeah,
that
let's
and
go
we'll
to
have
the
further
question of
discussion.
cardiovascular disease for now.
Prasad garu, let me just clarify one thing, and what Sridhar made. Sridhar, what I said is nothing to do with the antibody-dependent toxicity or anything. I'm saying that you do not need the booster dose. There is no evidence at this time. The booster dose are going to prevent, if it is a different variant, in younger population, anybody less than 65. Those who are above 65, because of their immune system is not as active as a younger population. And at the
And I'm
same
saying
time,
that
no, I said that. Plus, also it is immune deficiency patients. Again, we're not sure the immune deficiency patients respond even to the booster also. So there is not enough data to support it. But what I'm
Thank
So
you.
I
my
have not.
point,
What
I
we will
just
do
want
is
to correct this. I think we keep, just make one point. Don't use age alone as the risk factor. I'm saying there are many Indians who 50 years old have hypertension and diabetes and chronic renal disease. They are at risk. Are you categorizing anybody below 65 as being safe? I disagree. I think you have
I
to
did not.
estimate
I
risk
did not say
factor.
that. I'm
You
sorry,
just
I
I
did
said
not say that.
below
Suresh,
65 don't need it. You said.
No, that's immune deficiency. That immune compromisation is different below 65. It doesn't matter
Hypertension
the
is
age.
not an immune defect.
okay. Suresh and Sridhar, just what we
Let's
will do
go
is
to the
we'll take
chat
this
window.
discussion beyond this and let's do some of these questions which are in the chat box because
Yeah,
they'll
go
be
ahead.
disappointed.
Yeah, go ahead.
One of the questions is there a scoring system for severity of myocarditis and what are the poor prognosis indicators? Prasad.
Yeah, so the myocarditis we classify as mild, moderate, severe, and fulminant. These are the same definitions came out of the Utah. Utah is the kingmaker for the myocarditis, heart failure. So we use the same definitions, mild, moderate, severe, and fulminant. And
Wonderful.
of course, the poor prognostic indicators are the elderly patients who have associated hypertension, and people who have a pre-existent cardiomyopathy or regional valvular maladies. And of course, the severity of the disease has directly proportion to young patients who got a severe disease are also higher for this myocarditis with poor prognosis.
Prasad, is the LGE, percentage of LGE on the gadolinium scan, does that got anything to do with prognosis?
Oh, absolutely. The diffuse, if the entire myocardium enhances, that's a diffuse myocardial inflammation compared to patch. So the severity is, they do give a quantitative severity index.
Yeah, thank you. The other question is, what is the reason pre-COVID hypertensives become normotensives? I suppose the reason is the same which we are discussing is the autoimmune phenomena causing the POT syndrome and all that. So I suppose we will take that different question. Vimala Jayanti, my classmate, is online here. She says, so would you hold off the dose 3 on these young males? Vimala, welcome. And Prasad, what do you think? So we've had this discussion so far. I suppose we need to watch out for the space.
No. My personal opinion is if I have a third dose with a different, the third booster dose is exactly the same mRNA as the second dose. So if I'm at 25, I'll put it on my son who is at 25, is he going to get a third booster dose? Answer is I'll wait until they come up with the real booster dose with a different mixture of mRNA for the different variants. Whereas would I take it? Answer is yes. So that's the difference. So let's make it based on the evidence that we have.
Right. I think we will have to watch out for the space. As Sridhar said, there is definite evidence coming from the Israeli data that breakthrough infections are less when you do a booster shot. But I will wait for the space. And of course, FDA has their own reasons for that. The other question from this chat box is that some of them, Sri Nagesh wants you to share his PowerPoint. I'm sure we can organize that later. One question and the last question probably before we give it over to Sudhakar is, what do you think about these ACE inhibitors versus ARBs, hypertensive treatment in preventing COVID? Like, for example, COVID infection is mediated through the ACE receptor. And a lot of classmates of mine called saying that I am an ACE inhibitor, should I change to ARB? My understanding is there was a very good article in NEJM which clearly said there's no need for doing that. But I'd like your thoughts on that.
No, absolutely. The evidence is beyond confusion at this point. There is no need to change. And if the particular patient is a diabetic with proteinuria and needs to start on ACE inhibitors, I would not hesitate to start on either at the time of COVID or post-COVID mild symptoms. So answer is there's no correlation. There's no need to
thank
stop.
you for that. Sridhar, would you like to add something?
No, I think that's we published that showing actually ACE and ARBs are actually better. From a point where we were not giving it, that was the first month or so after COVID. After that, we use it wisely. We don't have any problem with that. So I would recommend using.
Two comments, Sivya, before you turn it over to Sudhakar. One is, I'm sure Sridhar has seen a good data, encouraging data is rather, I put it on statins in benefits in COVID. And I don't know, maybe it's just purely anti-inflammatory mechanism of the COVID high dose, probably is the beneficial effect. So keep that in mind, and maybe future articles are going to show up. And another most important thing is a comprehensive care for the COVID long haulers or the post-COVID. In our town, in 34 states in the United States now have what is called a COVID clinics. These COVID clinics are staffed by the mid-level providers with the supervising physician and a psychologist and a psychiatrist, because this is a multidisciplinary problem. We're going to start seeing tremendously in the next 6 months to a year. So please start planning for these COVID clinics that has services from the cardiologist, the psychiatrist, psychologist with a primary care. This is going to be a disease of the primary care, not any more disease of the infectious diseases. So I think that's my last suggestion before I conclude. Thank you.
Thank you, Prasad. There's somebody who wants to make a comment. Zoom user to everyone. Can I speak? He says, please go on. This is the last comment we take, and then we'll go to Sudhakar.
So thank you, moderator, sir.
Yeah. No, 1 minute. Naveen.
Yes.
CVR, you have more, you have a lot of time, we have not completed. I think we'll go up to 8 o'clock here. So you can invite more questions and discussion. There's no problem.
Okay.
Yeah, go ahead.
Wonderful.
Yeah.
Anybody
Naveen,
else
go ahead.
wants to ask any question?
Yeah.
Yes, sir.
Naveen, go ahead. Yeah.
Yes, sir. Sir, this is regarding anticoagulation post-COVID, sir. Sir, Hyderabad city, several corporate hospitals have seen a spate of cases of celiac artery and mesenteric artery thrombosis, small intestine gangrene, sir. So a few of them have died and a few of them have gone to ventilators, and there's been, and Vizag also has seen few cases, sir. They are asking to revise guidelines. They're publishing a paper, sir, from NIMS and prestigious institutes. Is it time for us to be less stringent on the post-discharge anticoagulation guidelines and so on? That's what their experience, sir. Over the last week, they have seen several cases of celiac and intestinal artery, mesenteric artery thrombosis, bowel gangrene, sir. Because
My
it is really
is, Naveen, as I said, I'm actually, all my research is on this field. At least I strongly believe we should put them on anticoagulants. The question is, I use Eliquis or Apixaban 2.5 twice a day. And if the patients have a high discharge or even outpatients, D-dimers, I use 5 milligrams twice a day unless there's a contraindication for 4 weeks. And I have seen about so many acute MIs that I end up doing STEMIs in these patients and people with strokes. So I'm kind of biased, but that's where it is. So yes.
Prasad, what is your cutoff? What is your cutoff for D-dimer for anticoagulation?
On the institution, ours is 250 milligrams per deciliter.
Okay, no, that's good. And that's what my understanding was, that if you have a high D-dimer, then it's highly recommended that you continue with anticoagulation.
Yeah,
I disagree again.
NIH is active 4, which is active 4 is we are looking at the people who are just hospitalized for 48 hours and they're discharged, irrespective of their D-dimers. We are putting them on Apixaban versus placebo, and we are doing this remote answering questions at 1 month, 30 days, and this is only a 30-day trial. So we'll see the data is still.
Sridhar wants to say something.
Yeah, I disagree with that. I think the current recommendation is based on the last two studies that came, which is NIH sponsored, by the way, that came from Canada, prospective randomized trials. Very well done, finally. I think so. Broadly, we divide COVIDs into two groups of people, those who have mild to moderate disease and those who have severe disease, those meaning severe, meaning the ones who end up in the ICU. The ones who end up in the ICU, routinely giving anticoagulants was not helpful. Actually, it was harmful. So the ones who are severely ill in the ICU, unless you prove that they have an embolic disease, like either you show a pulmonary embolism or an arterial embolus somewhere, then you can go ahead and give them anticoagulants, as Prasad said, that he would like to continue giving anticoagulation upon discharge. That is fine. But I think if you have mild to moderate illness, but the severe, again, the severe group, just because you have high D dimer, you shouldn't give anticoagulants unless you've proven that they have an embolic disease. When they gave them, they actually bled more and had worse outcomes. On the other hand, the mild to moderate ones behaved the exact opposite way. The moderate disease individuals, if they had high D dimers, and the cutoff was 1,000, by the way, then giving full dose anticoagulants for them, even if they did not have a clot, was found to be useful in them. So you have to be careful about how you divide up your patients, which is mild and which is severe, and accordingly use D dimers. But more importantly, I think the D dimer is at dynamic levels, and we published at least one paper showing that a static D dimer is not so useful. You want to do it 2-3 times during the course of the hospital, and when it rises, then it really predicts something is going on. And particularly if the D dimer starts increasing, I would image the person to make sure you're not missing pulmonary embolism or celiac thrombosis, as been asked about, and then treat it accordingly. I mean, once you find the clot, as Prasad said, then you give it. He said 4 weeks after discharge, and we agree with that. But I think you want to categorize them before just giving everybody anticoagulants.
Thank you, Sridhar. It looks like the way we are having this discussion, that means that the final word hasn't been said as yet, and a lot more information needs to trickle down that space. But I suppose whatever we have learned so far, we should be doing what we have been told. That's number one. Number two, Sridhar, while you're there, what do you think about molnupiravir? People are talking a lot about that.
I think it's not available yet, but looks like it's quite an impressive advance, because a 50% decrease in admissions and mortality is a lot better than anything we have short of monoclonal antibodies. So this will be a great advance once it comes, because monoclonal antibodies are not readily accessible to a lot of people, number one. They're very cumbersome to give. They, on average, take 3 clinicians and 2 hours to give, and you need a secluded place. This is just not feasible for a lot of people, and it's very expensive also. So I think this is a great, and it's an oral drug, which you give as soon as you think somebody has COVID, and it reduced death rates by 50%. That is quite impressive. So hopefully by the end of the year, we'll have it.
Oh, thank you.
I think
Prasad,
it will be available in India too once it's approved, because they contracted out to at least 2 Reddy's labs in India to manufacture it in India once it's approved. So hopefully it'll be available all over the world quickly.
Prasad, I have a question.
Yeah, go ahead.
Prasad, I have a question.
Yeah, go ahead.
What is the role of the statins in long COVID?
Yeah, there was some discussion which Prasad had mentioned about statins, and the final word is yet to come. Prasad, go ahead.
No, that's all in the acute phase, but not in the long phase. There's no data on the long phase about the statin drugs.
Prasad, one more word about the Regeneron. My understanding is they're usually given in people who are very sick and on ventilator in the ICU. Is that correct? Or you do give it for mild to moderate infections as well?
Mild.
No.
These are before the hospitalization. In fact, in the state of Florida, as you know, with this wave, we just acquired this enormous experience with this monoclonal antibodies. Both post-exposure prophylaxis, we give subcutaneous. It is literally everybody who comes to the ER, if they're not sick enough, we give a try and we send them home, because we can save the hospital beds, and I can tell you, it works like champ, man. I'm very impressed how it's been so useful to prevent overcrowding the hospitals.
Sure, it did work for Trump anyway.
Yeah.
Yeah, that's been our experience. We saw better than 80% reduction in death rates and almost 100% reduction in hospitalizations with our experience.
So what I did, Sridhar, is when we started seeing this spike, so all our physicians took antibodies for post-exposure prophylaxis, subcutaneous, because the third dose was not approved and we didn't want to wait until the booster. So we needed to protect ourselves. So all the people, when we make the rounds, we are exposed right and left every day, seeing 50 patients COVID. So it really helped us to get through this hump.
Thank you. We have Dr. Ram Kairam here. Would he like to come in and then give his thoughts on this?
I don't have many thoughts on a topic like this. I was waiting until the end to make an announcement about next week. So please proceed, Ram Prasad.
Oh, thank you. Vimala Jayanti says she works in a COVID recovery clinic and we have a robust protocol. And can I share it? She said, I suppose by all means, and I think it'll be very helpful for all of them. Please do send it to Sudhakar. He'll get it across. Vimala, you want to say something?
It was very insightful and very helpful for me, especially because we work in the COVID clinic and we do a lot of surveys like PHQ-9, GAD-7, quality of life. And we see a lot of POTS. So I agree with Prasad Chalasani about that. We see a lot of POTS.
Yeah, wonderful. Thank you very much for that.
Yeah, Vimla, I'll speak to you separately and we will have a session by you, if you agree. Okay, please get prepared. Yeah.
Right. Anybody else has got a question to go? Before, I think there must be some more coming in the chat box. I don't see any now. Can somebody help me understand what is the role of Ivermectin at this stage? Because a lot of people in India are getting Ivermectin for...
No.
No way. It has no role.
There's no role.
Yeah, that's
it doesn't
what my
work.
understanding
It has
was
no
because...
role.
Yeah, that's good. Thank you for clarification.
Yeah, Prasad Chalasani. This is Suresh. What is the role of antiplatelet drugs, especially in the cardiac issues with the post-COVID?
Post-COVID conventional indications. Otherwise, if I have a 25-year-old mild infection comes with chest pain, palpitations, PART syndrome, I don't start them on aspirin.
Okay, looks like we have exhausted most of the questions. Sudhakar, it's over to you. And thank you very much. I have learned a lot from all of these things. I will also tell you one more thing, which is the biggest dilemma and problem in Australia, because we don't have COVID, so we keep fighting over the vaccine. Australia has permitted AstraZeneca vaccine for people above 60 because below 60, they have seen cerebral thrombosis. And they've permitted Pfizer vaccine below 60 and not above 60 because they want Astra vaccine. And we have high incidence of myocarditis with that. So people are very scared of taking any vaccine at this stage.
I just want to clarify, it's not high incidence. It's there is no high incidence of myocarditis anywhere in the universe. There is some cases of myocarditis. Most of them are mild. So let's be clear on what.
Yeah, that's right. But in Australia, we've had a young man, 42 years old, who died from the vaccine, Pfizer vaccine, myocarditis, and that's where the whole scare came in. And we have another young person who had, AstraZeneca vaccine-related cerebral thrombosis, which has caused problem, and that's the reason why there's a lot of skepticism about vaccination here. Despite that, I think we've been doing reasonably well. We've hit the 60% mark this month.
I think the way out of the pandemic is vaccines. I don't think we'll ever get out of the pandemic unless we vaccinate everyone.
Yeah, around the globe, to be specific. Around the globe, we have to vaccinate. There's no way out of it. So let me give because we have a couple of minutes, I want to give a case and take an opinions. He is a psychiatrist, 80-year-old. My own uncle is actually my godfather in the United States. He received his third Pfizer shot on a Thursday, and he didn't feel good on Friday. On Saturday morning, he was alone. His wife had to go and visit son, and had a cup of coffee, and they found at 8 o'clock at night on the floor, and apparently died sometime in the morning. So we went for the funeral. The entire congregation was discussing and arguing about, especially in Louisiana, imagine about, I was the minority there, trying to say it's probably a coincidence rather than a third booster shot. And everybody continued to say, no, this is from a booster shot. So there's a lot of myths that goes around in incidents like this that takes away the best benefits of these vaccines that we could offer to stop this pandemic. You know, I was probably one of the top first 10 in the state of Florida to take the vaccine.
No, I agree with you. There are people who come in with chest pain and think that it is all vaccine related, but they have diabetes uncontrolled, blood pressure uncontrolled, smoking, and cholesterol hitting the roof, and they don't think that is causing the problem. They think it's the vaccine causing the problem. I know there are a lot of people like that. I agree with you. Sridhar, anything else to add? There's one more question coming up on the chat box here. It says, I'm working in COVID emergency and seeing almost COVID admissions are unvaccinated in the Caribbean. So I guess that's not very surprising. We have the world experience has been the same, that the infection rates are higher in people who are unvaccinated. Prasad and Sridhar?
Yeah. One other interesting thing is this spike, Sridhar, in Florida, with all our admissions are the breakthroughs. None of the previously infected COVID patients, not even a single patient was admitted to the hospital this spike. Very fascinating. I think a previous COVID infection really had some long-term benefits, though their antibodies may not be, I think the memory cells, whatever. So it's really good to know. I think the previous infection is a very protective. We have
now, Prasad, while you're there, people who have been infected, when they go for vaccination, my understanding is they get it after 90 days. Is that still the case, or is there a change?
No,
what's the question again?
Post-infection, people who are infected post-COVID vaccination, how do they plan? I mean, how long after the post-infection they get vaccine?
4 weeks after the resolution of symptoms, you can start.
Oh, I see. Only 4 weeks, because here they're not.
We no longer wait 90 days anymore. We give it in 4 weeks.
Okay, thank you. That's very understandable.
But again, I think if you got infected with Delta, you have time on your side, because there's no other variant right now anywhere in the world which is likely to infect you, because Delta has taken over the whole universe. It's only in a few countries like Peru where Lambda still persists, but rest of the world, Delta is the dominant variant. So if you got infected with it, you have time on your side. And so if you want to take it, you could take it within 4 weeks, but you could wait and you'll be okay.
Is it too premature to interpret that Delta has been there for a long time? There's no new mutation. Is this the end of the mutation for COVID, or we're prematurely concluding that?
Prematurely concluding that.
Because we wish
part of the world is not vaccinated, you know.
In a way, Delta, as devastating as it has been all over the world, it actually, in a way, helped in other ways, because it's just infecting billions of people and has left nobody left with a lack of immunity anymore. And so it's not allowing another variant to even emerge because of the rapidity which it's spreading and the billions of people that are getting infected. If you didn't die of it, you're in good shape. And if Delta persists, I think we may see the end of the pandemic a year earlier than we think. But we hope no other variant emerges.
Sridhar, your thoughts on, there's a trial going on, combination of flu vaccine and COVID vaccine to be considered yearly.
That becomes a reality in future.
I think that's very likely to happen because it'll take another 2 years to vaccinate the whole world, particularly if you take Asia and South America. So I think we will end up getting flu and COVID vaccine combination soon. Yeah, there's one that's being developed in India, actually, Novax, which can do both at the same time. And there's a few in the United States on the go. Moderna has a version of it where you could do both at the same time. But I don't think we're going to see them this year. It's most likely next year.
It is surprising given the fact that, here some people are recommending that if you take your COVID vaccine, wait for 2 weeks before you take your flu shot. Or if you take your flu shot, wait for 2 weeks before you take your COVID shot. Now that we are combining these two, I think it's interesting to see that, you can give them safely.
So the CDC no longer asks you to wait 2 weeks anymore. That's at the last year they used to do that, but currently you can take both shots the same time. There's no need to separate them, although my personal preference is to separate them if you're taking an mRNA vaccine. I think mRNA vaccines are prone to interference with much more than AstraZeneca or Johnson & Johnson or any of the adenovirus vaccines. These mRNA vaccines are quite sensitive to all kind of interference. So I still prefer to separate them by 2 weeks, but currently the CDC says that you could take both at the same time.
That's good to know. Good to know. Thank you for the update. There's no more questions on the chat box at this stage. I hand over to Sudhakar and thank you for the opportunity. And I have learned a lot of things from this talk, and thank you, Prasad, and thank you, Sridhar, for your inputs into this. Thank you very much. It's been a pleasure joining you all. I'm looking forward to joining for the other sessions too, now that it's in the morning.
I just have one question for Prasad, if I may. How many cats have you done, and what did you find? Because I think in the early phase of the COVID, no cats were done. We have done a few after that. And we find this diffuse endothelial activation in quite a number of these patients who will fall into the long COVID syndrome. So I want to know, what have you found in cardiac cats, if you did any in these post-COVID patients?
Post-COVID patients, let me start with the acute COVID patients. Acute COVID patients, we clearly define STEMI, pseudoSTEMI. Yeah. PseudoSTEMI, if you don't have a reciprocal changes, we don't cat them. We don't, because if they have, we learned through experience. But in the post-COVID patients, if they have a chest pain with ST elevation, we cat them. We see, in fact, a third of the patients with the Takotsubo syndrome. Believe me or not, a third of the patients have Takotsubo syndrome. And rest of the patients are all non-obstructive disease. Different ST elevations, non-obstructive. I think something to say about a possibility of pericarditis, myopericarditis kind of a thing, rather than a true thrombotic. But as I said, we have seen time and again, every month, a couple cases of classic thrombotic ST elevation MI, but they may have other risk factors, like a smoking history is a typical feature, which is high prevalence for plaque rupture.
I just want to follow up on the Takatsubos because we see them too. This is quite surprising to see them. What is happening with your Takatsubos 3 months and 6 months after you make
normalized ventricle? Normalized ventricle.
Normalizes. That's what
almost
we see.
100%. Yeah.
Yeah, they're going back to normal. Somebody asked statins. So during that period, we are giving them statins, maybe up to 3 months, and then stopping it at that point. That's what we're doing in terms of statins. But it's surprising how many Takatsubos people see at this with COVID. Yeah, that's all I have, Prasad. I'm done.
Thank you all. Sudhakar, over to you.
Yeah. Thank you, Prasad. Ramohan, if you have an announcement to be made, please go ahead.
I I sometimes do not manage to announce the following weekend speaker, but this time I've asked Dr. Bush Kavuru to speak again for the following reason. A week ago, I received a very long piece written by one of my ex-residents, a very heart-touching, very, very emotional piece regarding the so-called heroes of COVID war. You all remember 14, 15 months ago, people were banging pots and pans, honking horns, hailing the heroes of COVID war, all the doctors and healthcare professionals. But look what happened. Thousands of doctors, healthcare professionals and doctors are dead. And COVID is still exploding. People are still walking around without taking the vaccine. We killed off a lot of our parents, and now we will kill some children. He wrote, as a very active doctor taking care of a lot of COVID patients, how awful people's behavior is and how ungrateful they are not accepting the vaccine. Now, this is a CME symposium that Dr. Sudhakar conducts to spread knowledge. But I believe, personally, we should do more work on talking to patients, parents who have not taken the vaccine more than what we have done. Otherwise, we still have a problem for the next 4, 6, 7, 10 months. The mutants do not occur outside of an infected person. Infections must stop. And the guy who wrote is the pediatrician who's scared for his children. So I would like to ask all of you, I'm going to send that to you. Please read through that. Please read through that and appreciate what he's saying, whether you can do something about it or not. Following that will be Dr. Bush Kavuru speaking about what trauma, psychological, psychiatric outcome of this disease. That will be next week, Saturday. That's all, Sridhar. You will get an announcement.
Okay.
Thank you, Ramohan, for that input. Actually, I've gone through that post by your resident, and it's, as you said, it's very touching. And about this session, I'm very thankful to both Dr. Chalasani Prasad and CVR Prasad for having done it extraordinarily. And Dr. Sridhar, as usual, has given the latest that is available, and he cleared the air with regards to all the questions that have been asked in the chat box as well, with his own experience as well as evidence-based. And with that note, I thank each one of you for having logged in, and I'm sure that all these residents and the faculty got benefited by this particular session. And let's meet again next Saturday in the United States and next Sunday morning in India. Thank you very much. And with that note, I end this meeting.
Good night. Thank you.
Okay, bye-bye, Prasad.
Thank
nice
you.
to see you again after a
Thank
long
you.
time.
Thank you.
Good to see Vimla also.
We should
And,
probably get
Buji, it's
together
good to
sometime
see you
as
again.
1:1.
Okay, then.
Have a chat sometime, whenever you're free.
Sure.
Yes.
Okay,
All
bye-bye,
right.
Prasad.
Bye.
All
Bye.
Thank you.
Prasad.
Bye.
Bye.
Thank
Bye.
you. Thank you, Prasad, CBRK.
Thank you.
Yeah, it's
See you.
been nice seeing you again.
Yep.
Okay.
Yeah.
Bye-bye. Bye. Bye.
Bye.
Bye.